Well, welcome everyone. I think we'll get started. Hello, my name is Jillian McConnell. I am a knowledge broker with Brain Exchange, and on behalf of my colleagues from the MS Society of Canada Manitoba Division, Ellen Carr, I'm happy to have you on the call today. Today's webinar is the second of an 8-part learning series brought to you by MS Canada. And I'm going to be posting a link in the chat pod if you're interested in finding out more about our past or our future events. Before we begin, I want to take a few moments just to review the technology that you will be using this afternoon. The audio is provided over the phone, which means if you're hearing my voice, you're all set. And the visuals or the slides are provided by an online link that you should have received in the connection details. So that way you can watch the slides as our presenter speaks. On the bottom left of your screen, you'll see a blue bubble. And if you move your cursor or mouse over to it, you'll see where it says Chat with the Presenter. And if you click on that, that's the chat pod. And that is how you can communicate with me and how I've been communicating with you before getting started during the event. So please note that only our presenter and myself can see the notes that you placed in the chat pod, not your fellow participants. So that's also where you're going to be able to send your Q&A or your questions during the Q&A portion. So hopefully that's clear. I also want to make you aware, if you haven't already realized, that all of your lines have been muted for this event, just for the time being. And that helps us minimize any background noise or private conversations that you may be having on the side. If you do need to ask a question or if you have a concern during the actual presentation, I invite you to use the chat pod, as we won't be able to hear you, of course. The presentation itself is being recorded, and within a week or so, we hope to have it up on the MS Society Canada's website, and it'll also be starting on the Brain Exchange, or be available on the Brain Exchange site as well. So for the purpose of today, those are really the only features you need to be familiar with. The webinar is scheduled to be 90 minutes in length, and our presenter will speak for about 60 minutes or so total, and then we'll have the last 20, 30 minutes at the end for some question and answer and some discussion, hopefully. I do ask that you refrain from asking questions in the chat pod until the end of the discussion. Often your questions will be covered during the presentation, unless, of course, it's technology related or if it has to do with an acronym or a definition of some kind, and then we'll do our best to answer those because it's relevant as to you moving forward with the presentation. Okay, so now that the technical aspects have been taken care of, I do want to take the opportunity to review a few bits of information that the MS Society of Canada has asked that I share on your behalf. The MS Society wishes to gratefully acknowledge the educational grant received from Biogen, which makes possible this particular webinar series. The MS Society does not approve or endorse or recommend any specific product or therapy, but does provide information to assist individuals in making their own decisions. Identification of needs, determination of objectives, selection of content and speakers, educational methods and materials are solely the responsibility of MS Society staff and advisors. And also the mission statement of the MS Society of Canada is to be a leader in finding a cure for multiple sclerosis and enabling people affected by the MS to enhance their quality of life. And so we wanted to make sure that that was made aware to all of our participants today. So now we get to the good stuff, so to speak. It's my pleasure to introduce our webinar topic and our presenter for this afternoon. Today we'll be talking about bladder and bowel continence, and meet your friend, the pelvic floor muscle. And we're so pleased to have Dr. Kelli Berzuk with us today to present. I should mention that her accomplishments are many, so I will provide a bit of an edited version of her bio today. Dr. Berzuk is a pelvic floor physiotherapist and the owner of Nova Physiotherapy-Incontinence and Pelvic Floor Clinic in Winnipeg. And for almost 25 years, she has focused her clinical practice to the specialty of pelvic floor muscle health and the treatment of bladder, bowel, and sexual dysfunction, pelvic pain, and pelvic organ prolapse in men, women, and children. She received her postgraduate pelvic floor education through the American Physical Therapy Association, certification in pelvic floor rehabilitation and continence through the University of Melbourne, Australia, and a Master of Science Rehabilitation and PhD in Urogyne Colorectal Medicine at the University of Manitoba. She was nationally recognized within the first ever graduating class of Canadian Physiotherapy Clinical Specialists for her work in women's health medicine. Kelli is the recipient of the National Distinguished Service Award for her lifetime dedication to education, research, and clinical practice in the field of women's health and pelvic floor medicine, and the Distinguished Dissertation Award for her research thesis, Effects of Increasing Awareness of Pelvic Floor Muscle Function on Pelvic Floor Dysfunction. So we are very pleased to have Kelli with us today. And Kelli, I turn the floor over to you.
Wonderful. Thank you so much, Jillian. Can you hear me now?
Yes, we can hear you.
Perfect. Okay. So I want to start firstly by thanking Ellen Carr and the Manitoba Division of the MS Society and MS Society of Canada for including me and inviting me in these wonderful events. Ellen and I have worked together for many, many years at such events, and she's always such a lovely person to work with, and this is always such a feel-good group. I understand that there's a few people in the audience today that have put up with my presentations in the past, and I want to thank them for returning again. And for all of people new to me, I also thank you for this opportunity to present on bladder and bowel function and how this relates to the pelvic floor muscle. So my work is specifically focused on anything to do with the pelvic floor muscle, and I want to talk to you about the muscle quite a bit today. But the take-home message, I'm going to start off with it right away, is that whenever we have a problem with a muscle, there are so many things that we can do to help ourselves. So we're going to focus specifically on this muscle's role on bladder and bowel function, but it has other very important functions in addition to this. So while we're going to focus on this, you may, if you're starting to implement any of the suggestions that we talk about today or put forth, and you see improvement in other areas, I want you to stop and think, hey, this muscle, doing a little bit of exercise or giving it a little bit of care has really helped in many different facets of my life. Because if you sort of step back and assess all of the things that may have improved since changing your habits, it really motivates you, encourages you to continue the healthy behaviors. So I'm going to start off with my slides, as Jillian had mentioned, and then at the end there will be time for questions. Normally when I'm speaking, I encourage people to ask lots of questions while I'm speaking, but as Jillian said, it'll be a whole lot easier to just hold your questions to the end this time. So it'll be a little bit different format compared to what I'm used to for any of you there that have followed my presentations in the past. So by the time I finish speaking today, I'm hoping that you're able to understand the functions of the pelvic floor muscle and how it's specifically related to bladder function and bowel function. And I also want to spend some time talking about pelvic floor physiotherapy and what its role is in the treatment of bladder dysfunction and bowel dysfunction for people who have multiple sclerosis. According to the MS International Federation, 80% or more of people with MS will report bladder symptoms, and 50% or more will report bowel symptoms. Now, those are really high numbers, but I also want to mention the numbers are really high for people who don't have MS as well. So very often, we don't know how much of the symptom is coming from the MS complication and how much is coming from other factors. And sometimes it doesn't matter where it's coming from. It's more important to focus on all the things that you can do to live a healthy lifestyle and have a healthy diet and healthy behaviors and healthy exercise and healthy toileting postures and toileting habits for bladder and bowel health than anything else. So today we're going to go over a few of the definitions of symptoms that we often see with people who have MS. We're going to go over urinary urgency, urinary frequency, urinary incontinence, incomplete emptying of bladder, constipation, flatulent incontinence, and fecal incontinence. And again, the reason that I'm speaking on this topic is specific to the role of the pelvic floor muscle in all of these symptoms. So I wouldn't bring the symptoms up if the pelvic floor muscle didn't have a role in them. And by improving the health of the muscle, we can very often see improvement in the symptoms themselves and often actually complete resolution of the symptoms. So let's go back to the pelvic floor muscle. It has many different functions. It has a sphincteric function over the bladder and the bowel. So it opens and closes the holes that empty or control flow of bladder and bowel. It also has a supportive function. So it sits within our pelvis below all of the pelvic organs. So it sits below the bladder and the bowel and the uterus, and it supports them from below. It has a sexual function, and it plays a role in sexual function all the way from libido and arousal to sexual sensation and appreciation, all the way to orgasm for both men and women. It plays a role in respiration. It works with the diaphragm to help us breathe a little more easily. And it also plays a very significant role in postural and core stabilization. So anyone who has back problems, low back pain, if they keep their pelvic floor muscle healthy, can notice an improvement in the pain in their back, or it can allow them to have better posture, better stabilization. So for the purposes of this presentation, we're going to focus on the role of its sphincteric value on bladder and bowel health, as well as its support to the pelvic organs. But I wanted those other things mentioned because, well, as you probably picked up, I really love this muscle, and I want to make sure that it gets credit for everything that it does, because it plays such an important focus in our lives and is very, very rarely even recognized. So if you start making changes in your life to make your pelvic floor muscle healthier, and you see note improvement in other areas other than bladder and bowel health and support, I want you to step back and say, great, I feel even better about doing the work that needs to be done for the good health of this muscle. So here we have a picture of the pelvic floor muscle in women, and I'm going to show you. I'm just going to grab an arrow here. Oops. Sorry. Here is the pelvic floor muscle. It's this grayish area of sling, and it's a muscle that inserts anteriorly in the front in the pubic bone and in the back into the coccyx. And for women, it has an opening for the bladder to empty, it has an opening for the bowel to empty through, and then it wraps right around the uterus, becoming the vagina. And basically, this muscle, when it contracts, it can close these openings, and when it relaxes, it can open them. And men, oops, sorry, just a second, get rid of that. Men have the same muscle in their pelvis. So here we have it again, inserting in the tailbone in the back and the pubic bone in the front with two openings, so for passage to empty the bladder and the bowel. So now let's talk a little bit about bladder health. And while we know that we love to multitask and are often very proud of our abilities to multitask, for this woman, her ability to laugh, cough, and sneeze, as well as pee all at the same time, is one ability that we could do without. So let's talk a little bit about that. So I want to go through some of the definitions that we had mentioned earlier, or that I'd mentioned earlier. So firstly, frequency is the need to pee more than 9 times in a day or more than 0 to 1 time at night. We also don't want to be peeing less than 5 times during a day. So a normal frequency, normal amounts to empty your bladder in a day should be about 5 to 9 times in a day and 0 to 1 time at night. Urgency is that feeling of needing to pee with very, very little warning. So you're not thinking about your bladder at all, and all of a sudden, out of the blue, the feeling of needing to void just overtakes all other thought, and you have to get to the washroom very quickly. Nocturia, when we talk about nocturia, that's waking up at night to pee more than 1 time per night. And incomplete emptying is that feeling that your bladder is not fully emptying. When you went to the washroom to pee, you come away from the washroom and you feel like you never really fully empty your bladder. Urinary incontinence is the inability to control when and where you pee, and it includes anything from as little as a drop to complete bladder emptying. And according to the International Continence Society, they say that it's all about your control and your will. So if you peed a little bit when you laughed, coughed, or sneezed, even though it may not bother you, which is great, it's still considered incontinence because it wasn't your intent to let those few drops get by. And the reason that I sort of bring attention to that definition is because very often in society we joke about it. We talk about laughing a little bit or peeing a little bit when we laugh, cough, or sneeze. And we sort of make it out to be a normal phenomenon. And whether it's normal or not, it is considered incontinence if you didn't have the intention of letting anything come out. And again, the reason that I'm sort of harping on it is if we looked at those little bits of leakage, even when they're not that much of a bother or even if they're not a bother at all, if we get on them really quickly, we can usually resolve the problem quite quickly and effectively. Whereas if we sort of take the attitude, well, it's a little bit and it's not a big deal, I can kind of look past it, then the problem will really snowball and continue to get worse. So I like people to not get fussed about these things, not panic in any way about it, but just to recognize that no, that doesn't need to be like that. So even when it's just a few little drops, let's start taking note of that and changing some of our behaviors so that we can get rid of it before it becomes a bigger problem. Also, for anyone who is experiencing bigger problems already, so even anything up to full bladder emptying, I want you to know that very often by taking care of this muscle to help assist in closure around the urethra, to give better closure to the bladder, you can completely or significantly improve the symptoms and often completely resolve the problems. So it's never too late, but the earlier we start, the easier it is to correct them. There are different types of urinary incontinence. And the most common ones that we're going to talk about are stress urinary incontinence and urgency urinary incontinence. And when you have symptoms of both, we call it mixed urinary incontinence. So I'm going to talk about those now. So firstly, for stress urinary incontinence, that is any time that you increase the pressure on the outside of the bladder, so the stress on the outside of the bladder increases and there isn't a good enough closure on the bladder, on the urethra itself. So here, this is the pelvic floor muscle here, and this is the urethra, the tube that empties the bladder, and this is the bladder. And if we put pressure on the outside of the bladder, and we could do that with coughing or with jumping or just going from sit to stand or exercising, anytime we increase that pressure, if this muscle doesn't have a good closure right here on the urethra, then that downward pressure is going to push the urine outside of the bladder. So it's important that we keep this muscle very strong to compensate for these outside muscle pressures. Whereas in this next slide, we have an increase in pressure on the outside of the bladder, but the pelvic floor muscle was good and strong and tight and gave good closure on the urethra. So it didn't matter how hard we pushed, nothing is going to leak out. I often ask patients to think of a water balloon. If I was holding onto a water balloon and I squished the water balloon, if the knot on the water balloon is good and tight, nothing's coming out. The pressure is just going to be spread out throughout the balloon itself. But if the knot wasn't tight, then the water is going to come out through the opening at the bottom. So the balloon is like the bladder. Next, we're going to talk about urgency urinary incontinence. So what often happens is people will start off with symptoms of stress urinary incontinence and just not make a big deal about it. Don't do anything to necessarily change their habits. They may or may not talk to their doctor about it. And I encourage everybody to talk to their doctor as quickly as they can to get on this quickly and not let the symptoms get worse. So when we have stress incontinence symptoms that go unchecked, then we often produce problems with the bladder muscle itself. And that's when we see issues with urgency incontinence. And then when you have symptoms of both, then you have mixed incontinence, it's called. You could have just urgency incontinence without stress incontinence and vice versa, but the most normal pattern is that we first see stress incontinence, then urgency incontinence. So this gentleman is calling the incontinence hotline, and they ask if you could please hold. Urgency incontinence is that feeling that you have no ability to hold whatsoever. And the reason for that is not just because the pelvic floor muscle is not giving good closure down here, but in this case, this area here is actually muscle. The bladder is a sac of muscle, and this muscle is called the detrusor muscle, and when it becomes aggravated or irritated, then it starts to spasm. And that's when it gets very, very hard to hold back the urine from leaking out. That's when you feel like out of the blue you need to void and you may not make it to the bathroom in time. So then you need a pelvic floor muscle that is even stronger to give better closure to help compensate for this. So if your pelvic floor muscle wasn't very strong, if it was weak, it wouldn't effectively close the urethra off, leading to issues with leakage or urinary incontinence. But on the other hand, if the pelvic floor muscle doesn't relax properly, then the opening can't open as effectively and fully as it should. And then we can have problems with hesitancy, where you sit down on the toilet to pee, or for gentlemen, they might be standing at a urinal trying to pee or a toilet, and they feel like it takes forever to get going. Or you could have experienced symptoms of staccato peeing, where you start to pee and then it stops, and then you start and then it stops. Or you could have incomplete bladder emptying, where you feel like I had mentioned earlier, you pee but you never fully empty your bladder. And all of those types of symptoms, when you're not properly emptying your bladder, can often lead to urinary tract infections. So people who are experiencing hesitancy, staccato peeing, or incomplete bladder emptying are at higher risk of urinary tract infection. And the inability for the pelvic floor muscle to fully relax when it needs to, when we're supposed to empty, can be the cause of this or one of the causes. Now here's the thing. If your pelvic floor muscle is unhealthy, it can actually fluctuate between being too weak as well as having the inability to fully relax. So you can have all of those symptoms when your muscle isn't healthy. It's not just that you could have a very weak muscle or a muscle that has spasm or hypertonus, we call it. So the tone is too high and it doesn't fully relax. It's even more common that the pelvic floor muscle, when unhealthy, fluctuates between both. A muscle that goes too weak and then too tight and then back and forth through the cycles like that. So you can see that you want your pelvic floor muscle as healthy as possible so that it can have all the strength and endurance needed to keep the urine in the bladder so nothing leaks out no matter how hard you laugh, no matter how much you're exercising. But then when it's time to empty the bladder, when you go to the washroom, it needs to actually relax completely so that that hole is opened as much as possible to let everything come out and get a decent bladder emptying or a complete bladder emptying. So this is why when we see issues with incomplete bladder emptying, we can have a problem with the pelvic floor muscle, but we may also be having a problem with the bladder muscle itself, as I mentioned with urgency incontinence. If the bladder is in spasm, then it's going to be giving that feeling of needing to pee, even if you just emptied your bladder. So it's spasming, and now your pelvic floor muscle, you've got to really have a healthy pelvic floor muscle to compensate for that so that it can give good closure even when the bladder muscle is giving spasms. So sometimes it's one of the muscles not working properly, but very often it's both muscles. Somebody once sent me these pictures that she found on the internet, and this is not her in the picture. This is just pictures that were located on the internet, and I felt like this person really got it across to me what she feels like when she goes into a public washroom to pee. So I often include these pictures because I felt like for me this was a light bulb that turned on when I saw these. So if this person was going into that public washroom, gets into the washroom, and realizes that the walls are made out of one-way glass, the person that wanted me to understand what she goes through said, okay, Kelly, if you were sitting here trying to pee, and this gentleman over here walked up and leaned on the wall, would you be able to pee? And I had to think about it, and I really got a feel of what it must be like for this person in a public washroom when she sits into a public washroom and all of a sudden somebody is near the washroom, or a sound occurs in the washroom reminding her she's not alone, or something changed and they got a little bit anxious for whatever reason. Very often our pelvic floor muscle will start to tighten up, and you'll notice that your flow starts to decrease. And you may then not be able to fully pee even after you've calmed down again and relaxed a little bit. And that to me was a really great example of what can happen when your pelvic floor muscle isn't behaving perfectly. Because when it's time to pee, it should be relaxed through the whole void, through the whole cycle from start to finish. And it shouldn't be tightening up until you actually completely have finished peeing. So now if we talk about the same thing for the bowel, the pelvic floor muscle is going to work in the same way. If the pelvic floor muscle doesn't have a good enough strength or good enough endurance, then we're going to have issues with flatulence incontinence or trouble holding back gas. If that's left unchecked and nothing is done to correct that, then the muscle can become more and more unhealthy, and the bowel can sort of take over, and eventually this can sneak into fecal incontinence, whereas it sometimes will start to have loss of fecal content or bowel content that's really loose. So if you have diarrhea, you might lose a little bit of control. And then when it's even worse, you'll actually see people that can lose control of formed fecal matter too. So that's why I like to get in really quickly to help this person when it's just issues with gas, just issues not having complete control over gas. If we strengthen up that muscle, then they never even need to know what the next steps are like. But if you just put up with it and don't do anything about it, very often these symptoms get a little bit worse, a little bit worse, a little bit worse over time. So I like to take the little bit of flatulence incontinence as that good warning sign that, hey, my body needs a little bit of attention. I better talk to my doctor. I may want to consider going to see a pelvic floor physiotherapist. I might want to rethink what my habits are, and is there anything that I could be doing that would be a healthier choice for my pelvic floor muscle so that I could have improved bladder and bowel function. So that was what can happen if your pelvic floor muscle isn't strong enough or doesn't have the endurance that it needs to have. But again, just like with the bladder, if it doesn't know how to relax properly, it will never effectively open the bowel so you can have a good bowel emptying. And very quickly, this becomes a problem with constipation and chronic constipation. And what do we look at to consider constipation? If you're not having a bowel movement within every 2 to 3 days, then you probably are at the beginning stages of constipation. And if you're having it less than every 3 days, definitely talk to your doctor. It's time to consider what your dietary factors are, and we would probably also want to take a look at your pelvic floor muscle and making sure that it's able to relax properly to give a good emptying. All right, so I want to go through a few warning signs and just sort of ask yourself if these are things that ring true with you. it's vital to recognize the early warning signs of problems with your pelvic floor muscle or with your bladder or your bowel so that you can stop these progressions early on. But again, I want to say, just like I said earlier, it is never too late. So please, if you've had these symptoms for a long time or they're quite progressed, well, that's what we often see in our clinic. So it's never too late to make the changes. It's just easier if we can get these points across early on and fight it really quickly, because then sometimes it's a very simple fix, whereas if the symptoms are pretty pronounced and have been there for a long time, it sometimes takes a lot longer to correct. But again, never ever would I ever want somebody to think it isn't worth trying, because I have seen some cases where people have had complete bladder or bowel incontinence for decades and done extremely well, some completely resolving their symptoms. So in my opinion, it is never too late to try. We never know how great we can get it. And you're worth it. You deserve it. So ask yourselves these questions. Do you refrain from laughing wholeheartedly? If somebody was to tell a joke, would you be thinking only about the joke, or would you be giving a little bit of thought to your bladder? Or do you cross your legs when you sneeze? Do you leak urine when you cough or exercise? That to me is a really important thing. Can you imagine if somebody's leaking when they're exercising? I'm thinking that that's the first person who's going to give up on their exercise program. And as a physiotherapist, we want everybody to be as healthy and active as they physically can be to improve their overall health. So a little bit of bladder or bowel issues should not get in the way of your overall exercise and health. Do you have trouble holding back gas? So if you were in a crowded elevator and you needed to pass gas, what would you do? Would you be able to tighten your pelvic floor muscle and get good control and remain calm? Or would you get off on the next floor? Or, I don't know, would you, if the gas snuck out, would you just sort of look at the person beside you and sort of give them a dirty look and think maybe it came from them? Whatever it is, I want you to have the complete confidence to have control over your bladder and your bowel, and by keeping your pelvic floor muscle healthy, that's a huge step toward that. Do you know the location of every washroom around you or in your neighborhood? As you're driving around, do you already know where the nearest Tim Hortons or Starbucks or whatever other washroom might be around? Or do you tend to stay close to your house because of your bladder or bowel? Do you use the washroom more than 9 times in a day or more than 1 time at night? Do you have the feeling of needing to pee or have a bowel movement but have very little warning that it's coming? Do you often experience strong urges to void, or do you have to race your children or your grandchildren to the bathroom as you walk into the house? Or do you feel that panicky feeling that you may not make it to the washroom? Do you need to reposition yourself on a chair until that feeling of urgency passes and then race to the washroom? Or does your bladder seem to be contracting just as you pull up on your driveway or just as you get your key into the door? That is such a common phenomenon. It actually has a name. It's called key in the door syndrome. When you actually get into the bathroom, when you sit down, do you have trouble starting the urine flow? Or are you really heavily reliant on pads for protection? Do you limit fluid intake because of your bladder, especially if you want to leave the house? Do you avoid just in case every time you're about to leave your house, even if you just went to the bathroom half an hour ago? Have you ever altered any physical or social activity because of your bladder? Or do you feel that things just aren't the same as they used to be? Your bladder is much more finicky, or maybe for the women especially, do you feel like your pelvic floor muscle wasn't as toned as it used to be before you had your babies? Or over time, did it just become less toned? If you answered yes to any of those problems, or if you're experiencing frequent urinary tract infections, then there's probably an awful lot that you can do to improve your pelvic floor muscle health that will help your bladder and your bowel. And the converse is that if you just ignore it, the symptoms usually get worse. So the beauty of muscle is that it really wants to be healthy and it just wants proper attention and exercise. But the negative to that is when we don't exercise it or we ignore it and neglect it, the benefits of the strength in the muscle that we gain from exercise disappear quickly. Or if we've just never exercised it, then we see the negative impact of that. So I wanted to spend just a couple minutes talking about support from below, because remember I said that there were two functions of the pelvic floor muscle that I wanted to make sure to talk about today. And the first one was its sphincteric role in bladder and bowel health. And the second one was the support that it gives the pelvic organs, the bladder, the bowel, and the uterus. And the reason that I want to include it in this is because the support from below also will impact how the bladder and the bowel work. So here in our first picture here, let me get my arrow. I showed you this picture before with the pressure on the outside of our bladder. We increase the intra-abdominal pressure by laughing, coughing, or sneezing, and that puts a stress on the outside of the bladder, and that's why we call it stress urinary incontinence. But in this case, the pelvic floor muscle was nice and strong, and it didn't matter how much I laughed, coughed, sneezed, or exercised, nothing was leaking out. But remember that other picture I showed you had a weakened pelvic floor muscle that wasn't able to close off the urethra and compensate for this pressure on the outside of the bladder. But also, when the pelvic floor muscle is weak, it also doesn't support the bladder. So everything tends to sag down. The bladder sags down, the bowel sags down, the uterus sags down. You may have heard of these things called pelvic organ prolapse, where your bladder can sometimes tip and fall downward into the vagina, or the bowel does the same. Well, the pelvic floor muscle actually helps to support everything from below, never as good as it did when we were in our teenage years or before we had babies, for us women who've had children. But it plays a significant role in giving that last bit of support from below. So we want to help keep everything as high up as we possibly can. So not only do we want the pelvic floor muscle strong to give good closure on the urethra, but we also want it to hold everything up, because when this starts to sag down, you can see that the urine starts to sit on the inner lining here of the urethra, whereas the urine is supposed to be sitting in the bladder till we open it up, and then it comes down the urethra and is emptied. But if urine starts to sit right in the urethra, it becomes extremely irritating and much, much more likely to leak, and also increases the irritating factor and risk of urinary tract infection. So for those reasons as well, we want to always keep our muscles strong and healthy so that it supports everything within the pelvis. So I want to give you an image in your mind. I want you to think of a boat floating in the water, and it's tied up between two docks. So it has a rope on each side tied to a dock. The water level is high, and the boat is happily floating in the water. But what would happen if that water level started to drop? If the water level dropped, we'd have tension on those two ropes, and those ropes might start to tear or break, and or they would just stretch out. So now I want you to think of the boat to be a pelvic organ. It could be the bladder, it could be the bowel, it could be your uterus for women. And the ropes represented the connective tissue, the ligaments that were supposed to hold our organs up top, high up in our abdomen, like it did when we were really young. But with gravity and time and pregnancy and babies, everything sort of stretched out and sagged downward. Now we want to rely on the pelvic floor muscle, which is represented by the water level. If our pelvic floor muscle is strong and healthy, it sits higher. It's like a higher water level, so it holds the organ up so there isn't so much pull on the ligaments above. Does that make sense? By keeping this muscle strong and healthy, we do so many things. We close the urethra off better to have better bladder control. We close the bowel off properly to have better bowel control. But we also support the organs within the pelvis in a much better position so that they're better able to do their job that we expect them to do. As well, when the pelvic floor muscle is healthy, we have better oxygenation in the area. We have better blood flow in the area. Healthy muscle has healthy blood flow and brings better oxygen. If that's the case, we decrease our likelihood of having urinary tract infections. So it's important to keep this muscle good and strong and healthy for so many reasons. Now, I want to talk about conservative management, and the first thing I want to talk about is incontinence products. So pads, they have a lot of great points as well as they have some negative ones. And I'm always one of those people who thinks that it's better to know everything so we can make good decisions than not be aware of the information. So I like to educate my patients on everything possible with incontinence pads so that they can make the right decision for them. Because incontinent products and pads and diapers have a very, very important role. And we never want people to have to leave the house or not leave the house because they feel so concerned about having a leak. So we want them to protect themselves. So there is no doubt that incontinence products have a very, very important role. That said, they also have some negatives that we should be aware of when we're making a decision of whether or not to start wearing incontinent products, because there are a lot of people who will jump into incontinent products very quickly. And I always want people to fight first. Try to see what you can do to correct the problem early on. And it might be that there's a compromise here. You might have to wear incontinence products, but maybe we want to look at what type you should be wearing or how many you should be using. So firstly, the first thing I want to make sure to say is never use menstrual products in place of proper incontinence products. So there are some really great products on the market, like Kenna and Depends, that have special absorbency to actually hold the urine in. Menstrual pads are not meant to hold in urine, so they're not a good choice. The negative, as many people who buy incontinence products already know, they're very, very expensive. The absorbent chemicals can be irritating to people's perineum, so the tissues can become irritated. As well, if you have a diaper or a pad on that's urine-soaked, it increases your likelihood of getting an infection. So you want to change them frequently. The part that, as a pelvic floor physiotherapist, I like to always talk about is the fact that people will leak more if they're wearing a protective garment than if they're not. So if you're not wearing a protective garment, you will fight harder. You will grasp on everything that pelvic floor muscle has to give good closure, and you won't dig quite as deeply if you're wearing a protective pad. So I'm not saying not to wear them. I'm saying keep that in the back of your mind and think about it. If you're starting an exercise program, if you decide to seek out pelvic floor physiotherapy and get help and you're starting to improve, every once in a while, if you've been wearing pads for a long time, maybe think about whether you want to try in the house to go without a pad. Or if you're able to be around the house without leaking, you may want to venture out a little bit. Small amounts, and be careful about it. I don't want anyone to get themselves into a bad situation, but I do want them to sort of always think about, do I really need it, or have I become reliant on it? And it may be that you really need it, but if it's more a reliance factor, I would ask you to consider whether or not you want to try in small doses testing the waters, testing what happens when you're at home. It's great if you can keep the area, the perineal area, getting good airflow. So taking a pad away for a while is a really healthy choice if it's at all possible. The International Continence Society put out a very, very important textbook for the treatment of bladder and bowel health for people with MS. And in this textbook, it's actually a massive textbook that we follow. It's a 2-volume textbook, which anyone who works in the field is aware of it. And I took two quotes out of it, one for the bladder and one for the bowel, because I think that they really speak to the core of how we feel about bladder and bowel care and treatment. For the bladder, management should be focusing on symptomatic relief and should be as conservative as possible. So we always want to treat the symptoms and start out as conservatively as possible. And that certainly fits for a pelvic floor physiotherapist. That's certainly my philosophy with things. I want to look at what can I do in the most conservative fashion, what can people do for themselves to help themselves. So the very first things we're going to look at, and we're going to talk about this in a few minutes, is toileting habits and dietary factors, and of course, exercise. For the bowel, the comment is, or the notation in the textbook, is a regular bowel program should be implemented to prevent constipation, rectal overdistension, and fecal incontinence. So that's a really important factor that we keep on the forefront of our minds with every patient. We want to make sure that they're eating healthy, that their bowel is being given all the tools that it needs to be able to empty itself properly. And then we want the pelvic floor muscle, of course, to be as healthy as possible to hold back anything from slipping out when it's not supposed to, and to relax completely to have full bowel emptying. So if you choose to see a pelvic floor physiotherapist, that would be your very first step in a conservative management course of action. And the one thing that I like to always tell people is when they see a pelvic floor physiotherapist, get ready for a lot of education. The biggest tool that we have is empowering people with the knowledge of what's happening in their body and how much control that they have within their means to make a big change in this. So at my clinic, when we see patients, we book a 90-minute appointment for the first time we meet, and we spend a lot of time talking, just talking. It's, to me, the most important thing. So we want to, of course, take a very good and thorough history, medical history. What surgical issues have you had in the area? What's your obstetrical and gynecological history? Tell me everything about your bladder and your bowel and your sexual function. And I want to know anything that could be impacting the pelvic floor muscle so that I can direct you as best I possibly can. And then I start with my education. And I, as you probably have picked up, I talk a lot. So my poor patients are stuck in a room with me one-on-one for about an hour and a half, and we spend a good portion of that just talking. I want them to know how the bladder works, how the bowel works, and most importantly, you're seeing my bias, how the pelvic floor muscle works, because it plays such an important role in all of this. If they have symptoms that I'm feeling like, I'm not sure I've got a good grasp on everything going on, I think I'm missing something, then I may ask them to complete a bladder and bowel diary, which can be very, very helpful. But when I started as a pelvic floor physiotherapist about 20-some years ago, I used to ask everybody to complete a bladder and bowel diary. And then I did it myself. One patient asked if I'd ever done it, and I hadn't. So I thought, oh, she made a good point. I should really see what this is like. And it was a lot harder than I would have expected. So I now don't routinely ask everyone to fill out a bladder and bowel diary because very often we can tweak out the important factors in our history taking. And as well, we send home a questionnaire before we even meet with people. But if I feel like something doesn't quite make sense, then I'll still go back to use that tool with the patient's permission. We spend a lot of time with patients going over proper dietary factors and lifestyle corrections and alterations. So I'm going to go through a few of them right now with you. I put up a slide here of very common bladder or bowel irritants. So there are many foods and fluids that can irritate the inner bladder lining and cause that bladder to start to contract or spasm. And that's what gives that feeling of intense urgency. And if you're, so that's the bladder muscle itself starting to spasm. And if your pelvic floor muscle isn't ready for it or isn't healthy enough to compensate for it, then we're going to have leakage as well, or incontinence. So as many of you already know, caffeine is going to be the big one. So caffeine is a diuretic, and it's a huge bladder irritant. So how do I feel about caffeine? Well, nobody would want me on this teleconference if I didn't have my morning coffee this morning, and I would feel sorry for my husband and kids if I didn't. So I have to keep that in mind when I ask people to give up on their coffee. So I usually tell them that this is a factor that's really irritating to your bladder, and I want to know what's realistic. What can I ask of you that you're really going to be able to live with? And if there's somebody who has 8 cups of coffee a day, then maybe we'll compromise on bringing that down to 4 or 6 cups of coffee a day. And the reason that I can be a little bit easygoing maybe with this, or over the years I've learned this, even with that drop in 2 to 4 cups of coffee, they're going to probably already see improvement in control over their bladder within a couple of weeks. Some of them are immediately, within a couple of days. The other thing is when you drink that much caffeine in a day, I don't want anyone to get a rebound headache, because I'm already asking a lot of them. I don't want to give the poor people a headache on top of it, or they're never going to have confidence in me. So bring your caffeine back slowly and watch for the improvements. And then see where your bladder sits and bowel. Where does the urgency calm down? So very often we'll find that patients are fine if they have 1 cup of coffee in a day. They may have no problems with their bladder at all. Some are lucky enough to get 1.5 or 2. Rarely is it a lot more than that. But I would never just put out a rule for everybody. I would rather have everyone just sort of try it and see where that happy medium is for you. Smoking, that is another bladder irritant. So nicotine itself irritates the bladder lining. As well, it also decreases oxygen delivery. So if your pelvic floor muscle is not getting the oxygen delivered that it needs, it's not going to work as effectively. So smoking gives irritation to the bladder as well as compromises the pelvic floor muscle. Further, a smoker's cough puts a lot of strain through the pelvic floor muscle and often leads to incontinence. So smoking is a really tough one on the bladder. Regarding alcohol, it is a diuretic, and it will increase your urine output as well as decreasing your reaction of the messages that your bladder is sending, being full. So the messages as the bladder fills being sent up to the brain can sometimes be less clear under the influence of alcohol, as well as the coordination and balance between the messages being sent from your brain to your pelvic floor muscle to effectively contract to hold everything in your bladder, and also the messages being sent to the bladder muscle to contract when you want to pee. So alcohol plays a big effect on a lot of things as well with bladder and bowel habits. So for that, I would again say, how much alcohol do you consume? Let's try cutting back. Let's make sensible small steps in the right direction and see what the impact is. We can always take more away in time. And usually what we find with patients is if we ask them to decrease things, they start to decrease them even further when they know that they are irritating to their bladder and bowel, and as they start to see improvement. Artificial sweeteners are also very irritating to the bladder. And when I started doing this work a few decades ago, I was always very surprised at how many patients were referred to me with diabetes. And then a light bulb went on for me, and I started asking, when were you diagnosed with your diabetes? And let's say they were diagnosed 5 years ago, then I would say, did your bladder issues and bowel issues, did they start about 4 years ago? And I was usually quite close. So as people switch all their sugar to artificial sweeteners, they increase the amount of irritation to their bladder and bowel tremendously. So that is a really, really big bladder irritant. In addition to that, anything with bubbles, any carbonation can irritate the bladder. So for example, if you're drinking a Diet Coke, you're getting a triple whammy. You're getting your caffeine, your aspartame, and your carbonation. So you better really be loving it. Acidic fruit juices and acidic fruits can be irritating to some people's bladders. Not everybody, but some tremendously. So that's always one of those factors that I ask people to test on their own. So around Christmas time, when we see people consuming a lot of those great Christmas oranges, usually bladder urgency really goes up at that time. Spicy foods can irritate one person's bladder and bowel and bladder, and another person's not at all. So that's very case dependent. The rule of thumb, though, is if it irritates your bowel, it will absolutely impact your bladder as well. So things that bother your bowels are going to be bothering your bladder too, in most instances. Red food colorings and other food colorings can be very irritating to the bladder. So things like sandwich meats that have dyes in them, or Kool-Aid, or anything that has a strong color additive in it can be irritating to the bladder. And concentrated urine is a big bladder irritant. So many times we see people who will tell us that they decrease their water intake or their fluid intake because they're afraid of leaking. So they won't drink as much, so they won't leak as much. The problem with that is it works at the beginning. Initially, it's a good thing, so it reinforces these habits. But over a long term, actually, it causes a lot of problems and irritates the bladder lining considerably. So it really increases the urgency factor in urge incontinence. So it's not a good idea for long term. Okay. And then finally, fiber intake. That is another really important thing. We want to make sure that you're getting enough fiber and enough fluid and water in your diet so that your bladder and bowel are emptying nicely. So what are some of the other things that we would do as pelvic floor physiotherapists? We spend a lot of time on voiding and defecating toileting postures. So I know it's hard to believe that somebody would tell you that you're not peeing correctly or you're not having a bowel movement correctly. But there are actually scientists in the world that find the most perfect biomechanical position to have the best opening of your bladder and bowel so that you can most fully empty. So if you see a pelvic floor physiotherapist, there is a very high likelihood that they're going to be asking you these types of questions. And don't be shy. Don't hold back. They want to help. So the more information that you can give them, the better that they can guide you. Some things that I just want to make sure to say here, you should, for peeing, you should be peeing about every 2.5 to 4 hours, which works out to about 5 to 9 times a day. I mentioned that earlier, but I don't think I said the 2.5 to 4 hours in between voiding, and about 0 to 1 time at night. Now, the reason we have a range is because it depends on how much fluid you take in. So if your fluid level is really high, then I would expect you to be voiding closer to every 2.5 hours and about 9 times in a day, whereas if your fluid level is a little lower, then you should be closer to the 4 hours and about 5 times a day. But speak to your pelvic floor physiotherapist if you have one. If there isn't one in your area, talk to your doctor. They should be able to help you with that. Never hover over the toilet seats. If anyone is hovering over a toilet seat, please don't do that. Your pelvic floor muscle can't relax properly. So you need to sit down and relax. Now this is different than squatting. When you squat, if a full squat is achieved, you can actually relax your pelvic floor muscle. But the hovering, you know how when you're in a public washroom and you're afraid to touch the toilet seat, that kind of hanging over it? Don't do that. It really wrecks the pelvic floor muscle. As well as the Valsalva maneuver. When you're peeing, you shouldn't be forcing the peeing out. You shouldn't be straining. Even with a bowel movement, we don't want you to be straining. Try to relax and let everything come out. If it doesn't come out smoothly and easily, then we would want to take a look at your diet. Is your fluid intake level okay? Is your fiber intake level okay? Those types of things. Also with pelvic floor physiotherapy, we would spend a lot of time going over urgency delay techniques and relaxation techniques to fully relax your pelvic floor muscle when you're trying to have a bowel movement or empty your bladder, as well as how do you fight against that urgency so you don't rush to the bathroom all the time. Fight back. Your physiotherapist may be able to offer you acupuncture or tibial nerve stimulation to help calm down the nerves, as well as fully qualified pelvic floor physiotherapist is certified to do internal manual therapy. So they may offer vaginal or rectal work to try to relax your muscle. We may need to do trigger point release technique via the vagina or the rectum. So it's really muscle just like every other muscle in the body. So just like you can get myofascial trigger points in your shoulder muscles and around your neck, unfortunately your pelvic floor muscle is at risk for these as well. There could be scar tissues or adhesion that needs to be released, maybe from any previous abdominal surgeries or delivering your babies. Sometimes the ligaments in that area can be tight and restricted, and that might need attention. Or a physiotherapist may want to do visceral massage on your stomach to help get the bowels moving. So the viscera are just the organs, and if you're suffering with constipation, it can sometimes help to increase the movement, get the movement going. Very often for people with MS, we do a lot of education on relaxation of the pelvic floor muscle and teaching people how to relax and downtrain that muscle so that everything can open up when needed. And then when they're ready, we give everybody a pelvic floor muscle strengthening exercise program. And sometimes people can just do well with being taught how to do the exercises correctly and given a good prescription of exercise, and sometimes they need help. And if they need help, if their muscle is extremely low-toned, or if, let's say, it had been injured in child delivery, during a vaginal delivery, if it had a third-degree tear or a fourth-degree tear, for example, then we may need more help than just active exercise. We may look to computerized EMG biofeedback or muscle stim to help us out. So I'm going to talk up for just a couple minutes on that. Oh, sorry, I forgot about this slide here. So who is appropriate to do pelvic floor muscle exercise? Well, really, pelvic floor muscle exercise is appropriate for everybody. And if your muscle is safe to be exercised, and if you do the exercises correctly and you are given a good exercise program, then there really are no negative side effects. So that's the beauty of exercise. So you can see increased circulation, which improves your fight against urinary tract infection. It can prevent or correct problems with your bladder or your bowel, as we've been talking about for the last almost an hour now. It can give better support to the organs, as we spoke about. It can also improve your sexual satisfaction and appreciation. It can assist with your breathing, and it can give you better core stabilization and postural support. So the same exercises actually help all of it. So it's not a ton of exercise for each component. It's just getting this muscle healthy, just like every other muscle in your body. And exercise never will limit any future treatment options. So if you need pharmaceutical agents or surgical options, those are still available to you if exercise alone didn't get you where we need you to get to or where you want to get to. And most importantly, it encourages people to become very active in their own treatment plan. And we get a lot of mental and physical gain from exercise, so that can never be overlooked, how important it is to be exercising for so many reasons. Many years ago, I wrote a book, and it's called I Laughed So Hard I Peed My Pants, A Woman's Essential Guide for Improved Bladder Control. And it is available, I understand, in Canada at every major library. So it has all the exercises that are that we usually give patients. However, if you could see a pelvic floor physiotherapist, that would be better than reading exercises in a book. So a book is better than a handout, a pamphlet. It really doesn't give you nearly enough information. You should understand everything around it. But the best choice to make sure you're doing your exercises correctly is to actually see a pelvic floor physiotherapist and have your muscle assessed to make sure that you're doing your exercises correctly, to get a good exercise prescription. And if there's anything else going on with your muscle, then it can be treated at the same time. So that's always the best thing if that's possible. That said, we know that not everybody has a qualified pelvic floor physiotherapist in their area. We also know that in Canada, coverage for this is usually not covered in our health system. It's usually private therapy, just like my clinic is a private practice as well. I know I'm working with government in hopes of seeing a change in that, but that's not something that's going to happen quickly. So in the meantime, there is this available at the library in case that's helpful to you. When we see patients, we may talk to them about biofeedback. And biofeedback is a tool that we can use by putting a sensor into their vagina or rectum and letting them see how they're contracting their pelvic floor muscle versus another muscle. So for example, if they're having trouble relaxing their abdominal muscles and really doing everything with their abs and nothing with their pelvic floor, or a combination of it, this gives them the visual feedback and improves their awareness as to which muscle needs to be contracting and which muscle should be relaxing. So this picture is just an example of that equipment. Another very useful tool, especially for anyone with a neurological component, is muscle stim. So it's called neuromuscular stimulation, or NMES, or sometimes it's just called electric stim. This is a tool that I use a lot for patients, especially if I know that they have a background with an MS diagnosis. And basically, it helps to activate the muscle and get the muscle to be contracting even better than what you can actively do on your own at the beginning. And then as your muscle improves and as you get the feeling of how to contract this muscle properly, then you don't need the machine. And your own exercises are really the most important thing. But sometimes it's hard to find that muscle or to get it to contract properly right off the bat. So then we use this device to get things going. And I have a couple more slides. I know I'm about to wrap things up, but I want to just go over these really quickly because I found this very important. Back in 2006, a pilot study came out in the literature, and it looked at patients with MS that were allocated into groups 1, 2, or 3. Group 1 was given pelvic floor muscle training, pelvic floor muscle exercises, and education. Group 2 is given pelvic floor muscle exercises and education as well as biofeedback, EMG biofeedback. Whereas Group 3 got everything. They got pelvic floor muscle exercises, they got the education, and they got EMG as well as the muscle stim. And of the 3 groups, after 9 weeks of treatment, Group 3 demonstrated superior benefit to the other 2 groups, to Group 1 and 2, when we measured, or when the researchers measured the number of leaks or pads that were being used. So at that time, we already knew that muscle stim was a really important treatment option when we were working with people who had an MS diagnosis. And then these researchers actually went on in 2008 to do a full research study specifically for using muscle stim. So that was the one big component that seemed to really jump out in the treatment plan. So they split the patients up into a group that got muscle stim versus a group that got sham muscle stim. So it was fake muscle stim. The machine wasn't really doing what it said it should do. So the patients had no idea whether they were getting the real treatment or the sham treatment. But the study showed that they were the group that received the active muscle stim, the real muscle stim, had statistically significant reduction in incontinence episodes compared to the sham group. So again, we were showing that this is really an important treatment tool for that population. And for me, that was really important because it can sometimes take longer to treat patients that have MS or a neurological disorder than patients that don't have it. Not always, but it can. And we always want to make sure that if people are trusting us to come to our clinic and they're paying for our services, we want to give them every best advice and guidance that we possibly can and as quickly as we can, because we don't want to waste their insurance, or we don't want to waste their time or spend their money on anything that that isn't really critical for them to know. And sometimes, because muscle stim was the more invasive treatment option in pelvic floor physiotherapy, it's a little bit more invasive than, say, just exercise alone. we might be a little hesitant to not talk to our patients about it right off the bat. And I've learned because of the research, don't hold back. Tell people everything that's available to them and let them make the decision that's best for them. And that's how I like to work as a clinician for my patients. So in conclusion, I just want you to know that there is so much that you can do to improve your symptoms of bladder and bowel dysfunction or to prevent problems. If you're not having any problems, that's wonderful. But don't think you're out of the woods, because unfortunately the risk of getting problems in this area is really high. We know the likelihood is very high. So find out what exercises you should be doing to prevent problems. I'm all about prevention. Keep this area healthy. It will help for so many reasons. As well, there are lots of pelvic floor physiotherapists in North America. They want to help. If you don't know where one is, you can call the physiotherapy college in your province to help locate the pelvic floor physiotherapist near you. In the U.S., the American Physical Therapy Association would as well be happy to guide you, I'm sure. So I think that's it for me. Are there any questions? I hope I didn't bore you guys. I hope this was useful.
Thank you, Kelli. This is Jillian speaking. So thank you all for your attention in this, and Kelli, great presentation. And it's always lovely to have those bit of visual breaks when you have some of those little cartoon or funny things, or the pictures and so on. So thank you for that as well. From someone who's seen a lot of PowerPoint presentations in her lifetime, it's always nice to keep things interesting and appealing to the eye. So in addition to the wonderful content. So thank you for that.
Thank you.
Before we get started with the questions, I do want to remind people that they have a couple of options and with respect to how to ask a question of our esteemed presenter today. So you can do so in two different ways. You can type your question into the chat pod, which I see a number of you are already doing just that. Or if you would prefer, you can ask over the phone. And to do that, you would have to press *7 on your individual phone line. I would ask that only those who are interested in asking a question over the phone unmute their line, because otherwise with over 100 and some odd people on here, it can get a little busy if we all unmute ourselves. And also too, I just wanted to give you all a bit of a heads up. I'm just posting a few poll questions during the last 15 minutes or so. So I invite you all to answer those before you leave. I believe there's 5 of them in total. So please stay on right till the very end and listen to some of the Q&A, even if you don't feel comfortable asking a question, because we would really like to have your poll responses as well. Okay, so enough of that. We're going to jump right into the poll questions. I'm going to start with the chat pod. So the first question is, and by the way, I'm keeping these all anonymous, so no one else can see who's asking, just me. And the question is, I get Botox injections in my bladder to help with my hyperactive bladder. As a result, I have intermittently catheterized because I cannot empty properly. Will I be able to exercise those muscles, and if so, will it make a difference?
Oh, that's an excellent question. Thank you so much. And absolutely, you are able to exercise your pelvic floor muscle, and it definitely has the potential to show significant improvement. I can't say let's see, I've done this work for about, over 20 years, and almost never has it occurred that people did their exercises correctly and diligently and didn't see some benefit. So I can't say it has never happened, but I've seen thousands of people, and I can probably remember a couple that actually did not get better, and then there was complications we found out afterward. But really, the idea of it not helping at all would shock me, as long as your exercises were being done with the correct technique. And the medications should not impact your pelvic floor muscle exercises at all. So what you may find is that as you strengthen your pelvic floor muscle, you may want to talk to your doctor about as things are improving, whether or not you're able to come down from from the medications. You might not. That's between you and your physician, of course, and I can't really talk to medications. I'm a physiotherapist. My PhD is in urogyne colorectal medicine, but I'm not an MD. I'm not a medical doctor, so I cannot speak to medications because that's outside of my scope of practice, I'm afraid. But I'm certainly able to talk about exercise while you're on medication, and that there should be no worries about adding exercise into it, and I would certainly expect significant improvements. Thank you for asking that one.
Thank you. Okay, so next question, and I've actually had a couple of people ask this, so hopefully this will coincide with a number of individuals. I have bladder and bowel incontinence. I do not have a pelvic floor physiotherapist in my area. Are there any specific pelvic floor exercises that you could share with us today?
Okay, absolutely. And I'm sorry, I know that is definitely a big problem, that access to pelvic floor physiotherapy is limited. It's so much better now than it used to be. You know, there used to be maybe a handful of us in North America, and now, well, in my clinic alone, we have 7. We have our 7th one joining us now. So provinces in Canada certainly are increasing the ability to offer treatments, but I also know coverage is usually, financial coverage is usually a factor, because very rarely do provinces have it covered within the health system. So absolutely, I'm happy to talk about the exercises, but like I had mentioned, the best way to do it, the first choice is to have your muscle assessed first. But with that book that I had talked about that's available at the library, it will talk about exercises. And the 2 things that I want to really remind people if they're doing their exercises is, firstly, to remember to think about where the muscle is. So if you need to see that picture again, those pictures that I put up actually are all in the book, reminding you where it is, and try to always contract the pelvic floor muscle alone at the beginning. So if your tummy is contracting or your bum cheeks are clenching, that's not the right muscle. It's the muscle in the pelvis between your sit bones that you're sitting on, in between those, running from your pubic bone in the front to the tailbone in the back, the same muscle that you would try to tighten if you didn't want any gas to come out or you didn't want any urine to leak out, sorry. And then the second thing is, I want you to do some long ones and some quick ones. So in the book, and this is sort of a general exercise program that if we don't have the luxury of being able to assess somebody's muscle and give them the perfect exercise prescription for them, then generally speaking, something like this is going to be okay for most people. Tighten and hold that contraction for a count of 5. So tighten your pelvic floor muscle. Try to lift it up and in. Make sure you're not pushing it out. I don't ever want you to bear down like you're pushing out a baby. Tighten up and in and hold for a count of 5. And then rest for a count of 10. And I'm going to double the rest period because I'm assuming that you've never done these exercises, and this muscle will get fatigued very quickly. So don't exercise an over-fatigued muscle. So if you are fluent in doing these exercises, then please do not double the rest period. But for those of you just starting, hold for 5, rest for 10, and do it 5 times. Then I want you to do quick ones because this muscle has fast twitch fibers and slow twitch fibers. So you've got to do both of them. So now the quick ones are just tighten up, let go, tighten up, let go, tighten up, let go, tighten up, let go, tighten up, let go. So you've done 5 slow, 5 quick, and that's 1 set. And an hour later, do it again. And by the time you go to bed, try to do 10 sets a day. It would take you about a minute to do 1 set, so we're only talking about 10 minutes of exercise in a day. At first, you need to spread them out, but as you build up endurance, you can push them in together and do 2 or 3 or 4 or even 5 sets together at a time for a total of 10 sets. At the end of the day, by the time you go to bed at night, try to have done 10 sets. Also, mix up the position that you're in. So at first, I want the gravity not pulling down on your muscles. So start lying down and take gravity off the muscle. And as you get better at it, do it in sitting and standing and maybe even walking. How's that?
Thank you. I have a feeling that if I let you go, we could probably spend another half an hour on just talking about different exercises.
Yeah.
So,
well, I hope so.
We have lots more questions coming in.
Okay.
I think this is actually a popular one, and so I think I'm asking on behalf of a number of people. How do you feel about the tampon-like product to prevent bladder leakage that's advertising a lot on TV?
Yes. Okay. Great question again. You guys have good ones. I'm actually on committees that review these products, and that one I think has a lot of promise. When I was in Australia at the University of Melbourne, in Australia they were offering a different product but a similar makeup of a product, and a lot of women really liked it. And I like the idea now that they're making it specifically with this purpose as opposed to women just wearing a tampon in hoping to do the same thing, because the tampons have absorbent chemicals in them which are not good and healthy. So we don't want you to put in 1 or 2 tampons and have all those chemicals in your body when that's not what this is about. You just want a support system. So some patients I know really, really like this option. Some don't benefit from it. But as a pelvic floor physiotherapist, I will repeat, please try them. It's really worth trying and see how you do with it. But you still have to do your exercises. The exercises are for so much more than just that. So that will mechanically or physically give support, especially if you have a hypermobile urethra. It'll help to give support. But by strengthening the muscle and making the muscle healthier, one, you may no longer need that support system because the muscle might be able to do it for you. And two, those exercises still need to be done for good health of your pelvic floor muscle to support the organs and to allow good emptying and closure. So even if they take the leakage away, don't just rely on them. Please still do your exercises. You deserve it. But that particular product or those products that are now coming out, they've got some really good promise, and some people really like them. Not everybody, but rarely do we find something that works for everybody, except pelvic floor muscle exercise.
Thank you. So we're getting lots of questions about the benefits or the merits of prescription medications for incontinence, as well as the use of a physiotherapist. And one person is saying that although their MS clinic, all they want to do is prescribe medication rather than prescribe the services of a physiotherapist. Why would they do that when the meds could possibly have side effects? And as you're indicating today, there's some definite benefit to attending this or using the services of a physiotherapist as well. So I know that's a convoluted question, but can you touch a little bit on the meds and using them in conjunction perhaps with the therapies and if there's side effects with the medications?
That's a good question. And again, I'm going to have to go back to outside of my scope. I can't really talk about medications specifically. However, I am a scientific researcher, and as a researcher, I can certainly tell you that absolutely those medications have side effects. So sometimes you have to have them, and please do not stop any medication. Talk to your doctor. I don't have a clue what reasoning certain medications might have been prescribed to you specifically, so please do never stop taking your medications. Talk to your doctor if you want to. However, research tells us that if you need to be on medications, you will still get better results if you exercise as well. If you're doing pelvic floor muscle or physiotherapy or exercising your pelvic floor muscle, those things all augment the medications. So yes, medications usually, almost always, come with side effects. So that's something you have to talk to your doctor about. Whether you want to stop your medication, you have to talk to your doctor about it. There is never a contraindication to having pelvic floor physiotherapy while you're taking medication. That's not a problem. But if you're getting better and resolving the problem or improving, you may want to talk to your doctor about, do I really need as much medication as I'm on, or can we talk about this? Open up the conversation. I hope I answered that well enough.
Well, I'm going to keep going because there's lots of questions coming in, so I'm hoping to try to capture as many as I can before we run out of time here. I'm just going to combine a couple of questions that have snuck through, and that is with respect to those tampon-like products that we were talking about earlier. Number one, can a person still urinate with those in? And number two, in keeping with that theme, toileting postures, and what do you think about the squatty potty, which has been out there?
Good one. Okay. Yes, usually they can still pee with those products still in. Most of them are like that. But read the packaging to make sure, just because there could be other ones out there. I'm not, what if I'm talking about the wrong one. But even pessaries, you should always be able to pee with it in. Very rarely is there a pessary out there that would include being able to void or have a bowel movement or empty your bladder with it in. And if that is the problem, if you're having a problem emptying your bladder with that device in, that's a concern. So please talk to your doctor or your pelvic floor physiotherapist. They would want to look at that. So you should be able to still pee properly. The other question was the squatty potty. Usually pelvic floor physiotherapists really like the squatty potty. So now and I'm going to just expand a little bit because most of these are just the stools under your feet as you sit on a toilet, but there are other products that sometimes you actually squat over. So those are two different kind of things. So the ones that go under your feet to bring your knees and hips up while you're sitting on the toilet, that is highly recommended by most pelvic floor physiotherapists. Now, of course, I'm talking in generalities. Every patient is of a different height, so we would prefer to assess you and how you're sitting on a toilet before giving that advice. But most of the time, unless people are very tall, years ago, I would have just asked them to please put some phone books underneath their feet to raise their knees up and hips up. Now they make a nice little stool that you can buy that slides right up against the toilet and gets nice up and nice and close to the toilet. So that's a great thing. And then the ones that you actually squat over, the toilets you squat over, again, it all depends on whether or not you can fully relax your pelvic floor muscle. As long as your muscle is relaxed, then you're fine. It's the hovering over toilet seats that I am very worried about.
Thank you. Okay, so I'm trying to push through here. I think probably we'll get the last one in right now, but I think this is a key issue, so I'm going to ask. I have a bladder and bowel issues. After a bad relapse in March 2016, I prolapsed. I desperately require pelvic floor physio and NMES urologist. How on earth can I make this happen when I can't afford it? I really need this help.
Oh, I am so sorry to hear this, and I have to admit that this is something that we hear a lot of. One comment I'm going to make, maybe I misunderstood, but was the NMES connected to a urologist? Because usually pelvic floor physios do the muscle stim. We do muscle stim all the time. I don't know in my area of urologists that would be doing it. So maybe I misunderstood that in the question.
It was just NMES and then brackets urologist. So.
Urologist, okay. So there could be urologists out there that are offering it. It's just not what we normally see. That's usually something.
The person who said urologist suggested that they need to see a physiotherapist for that.
Okay, that makes sense. So, okay. So now we're getting back to the money thing, and you know what? I have worked with government in my province. I also tried to work on a national level on making them see how important pelvic floor physiotherapy is and how the therapy, the conservative management, can often decrease the need for medications and surgeries, and in that way decreases the cost on and burden, a financial burden on our medical system. And this is something that is ongoing. And I realize the question is for here and now. What do we do right now? And there are so many people in that specific category, and I am so sorry I don't have a good answer. My field of pelvic floor physiotherapy, of which I'm so proud of, has two big problems. We are well aware, and we are trying very hard to work with government and with our colleges and licensing bodies on both. The one problem is our own education, to make sure that we're always raising the bar and getting very great education in this field to be the best clinician that we can be for our patients, and that we're current in the literature around the world, that we attend conferences around the world. The other part that we worry about all the time is exactly this question, and I'm so sorry I don't have an answer for you. What do you do when you just cannot afford these services or they're not available in your area? The one thing I know here in Manitoba, I work with the family physicians, and sometimes I will have a family physician phone me and ask me things so that hopefully they can work specifically with the patient. But that's certainly not optimum. They don't have the time or the knowledge and education on pelvic floor muscle therapy. But sometimes we have to take, I guess, something is better than nothing. But I'm sorry. I agree with you that it would be so appropriate, and you deserve it, and I don't know what to say. I'm sorry.
Okay, so Kelli, I know that we are at time, and I'm going to hold you to the fire for one more minute, if that's okay, because the questions are coming in, and I think that this is important to get out to because it's been asked a few times. So I'm sort of merging questions here. If a person has hypermobility, or alternatively, if someone has suffered from a spinal cord injury of some kind, would they still benefit from the exercise programs that you're suggesting?
Oh, that is a great question, too. My routine answer is yes. We can never say 100% that these things are going to work for them, but it's exercise. What's the worst thing if it didn't work? It doesn't happen very often. In all the years that I've done this work, at my clinic we see people with all different backgrounds, medical experiences. We've seen many spinal cord patients. Usually, if it was a complete spinal cord, severed spinal cord, then that would be a different case. We would have to know what abilities are still left in the nerve function going to the pelvic floor muscle before we would make that determination, because we would never ever want to raise false hopes. But if it's a partial injury, then there could still be lots of nerve fibers that are left that have the ability to regenerate. So I would always want to try, but a pelvic floor physiotherapist would be able to assess what limitations are there that we know about for sure to possibly say differently for a specific case, especially, for example, if it was a complete severing.
Okay, well, thank you so much. I'm going to hold you there. I've already taken up a little bit more time than what we had promised. So there was a question about someone asking about the guide or the book that you had referenced, so I just wanted to post that really quickly again. And, of course, Dr. Kelli Berzuk is the author of this, so if you're interested in looking at that, someone was asking for it. I do want to thank everyone so very much for their participation this afternoon. It always makes for a great event when there's this type of interaction and interest, so thank you very much. And, of course, Kelli, I really, really want to thank you for your time and expertise today. It's been really, really valuable, and I've learned a lot, too, as well. I do want to also provide just a few reminders before everyone leaves. A recording of this webinar will be available on the MS Society of Canada website, hopefully within a week or so. So I've posted in the chat pod the link, but just check that out on the mssociety.ca/webinars. It's also going to be in Brain Exchange as well, so you can check it out there. Today's events are the second of an 8-part learning series, so please keep your eye out for the future sessions that we have coming up in the next few months. And also, finally, that you will very shortly be receiving an email requesting your participation in a survey from MS Canada having to do with this particular event. So please keep an eye in your email inboxes for that, and please It doesn't take very long to fill out, but the information is very, very important for the MS Society of Canada to keep apprised of your thoughts and feelings about these events and future events. We do have Ellen Carr on the phone from MS Canada, Manitoba, to say a few final words. If you have a moment, Ellen, are you there? Oh, Ellen, I don't hear you. I think just press star 7.
Sorry, Jillian, this is Kelly. I just want to make sure that I get to say thank you to you for all of your work, and to Ellen for everything that she did, and to all of you people who joined. Thank you so much. Those were excellent questions, and I really loved this opportunity. So thank you, and I wish you all the very best.
Thanks so much, Kelly. And Ellen, are you there as well?
Yeah, can you hear me now?
I can, thank you.
Okay. Really, I just wanted to say it was a pleasure for the Manitoba Division to be able to host this wonderful webinar, and thanks to Jillian for moderating, and especially to Kelly for her absolutely outstanding presentation, and for everybody who brought so much to this session with their wonderful questions. I hope you all learned something. I always do when I listen to Kelly. So thanks again to everybody, and have a great day.
Thanks all. Take care, and hopefully we see you in next month's session as well. So thanks all. Take care. Have a good day. Bye-bye.